monoclonal gammopathy is a relatively common condition, especially in the older patient population. In patients over 70 years of age, almost 6% of patients will have a monoclonal protein in their serum or urine. The vast majority of these patients actually have monoclonal gammopathy of undetermined significance. The majority of these patients, almost 80% of them, never progress on to a stage where they would need any treatment for that. About 20% or about 1% per year of patients with MGUS will go on to develop myeloma or a related condition. Now, there are certain risk factors that have been identified that will help us predict who is at a higher risk of progressing to multiple myeloma or a related disorder. What we do know for sure is that all patients with myeloma start off with a MGUS, and we believe that it probably takes about 10 to 15 years before the start of the MGUS to transition to multiple myeloma. In a smaller group of patients, we can also identify an intervening stage which we refer to as smoldering multiple myeloma. Now, this is a condition where the plasma cell burden or the clonal plasma cell burden has increased to a point where you have higher levels of M protein. You also have more bone marrow plasma cells in the bone marrow, and there may be other changes also that we can detect, but still not have any end organ damage in the form of bone disease, renal insufficiency or anemia or hypercalcemia that is typically associated with active multiple myeloma that needs treatment. Now, in contrast to monoclonal gammopathy of undetermined significance, patients with smoldering multiple myeloma have a much higher risk of progression to myeloma, roughly about 10% per year for the first 5 years, and then about 3% per year for the next 5 years. And beyond the first 10 years, most patients have the same risk as MGUS, which is about 1% per year. Now, there are several implications as to the identification or the diagnosis of these precursor conditions, both from a routine clinical practice as well as from specifically from a treatment standpoint. Now, one thing these precursor conditions allows us is that it provides us with a potential to examine if early intervention could actually alter the natural history of this disease. But at the same time, currently we have very little evidence to suggest that intervening early can make a difference for these patients. So, it is important that we do randomized clinical trials to demonstrate an improvement in overall survival by intervening early in patients with precursor disease. Until such data is available, we have to be very carefully making the diagnosis of these different precursor stages and then carefully following them. Now, the diagnosis of these different stages have been better defined by the International Myeloma Working Group based on the diagnostic criteria that was developed a couple of years ago now. So, based on that, patients with monoclonal gammopathy of undetermined significance is diagnosed on the basis of an M spike that is less than 3 grams per deciliter, bone marrow plasma cells that are less than 10%, and 24-hour urine M spike that is less than 500 milligrams, and obviously no end organ damage. Now, the smoldering myeloma represents an increase in the plasma cell burden. So, now you have M spike that is more than or equal to 3 gram per deciliter. You have M protein that is more than 500 milligrams for 24 hours in the urine, and bone marrow plasma cells more than or equal to 10%, but still no end organ damage. Finally, the diagnosis of myeloma itself has changed over the past couple of years with the new definitions that were developed. Now, the reason for developing the new criteria is important from when you think about the whole philosophy of treating early or intervening early. So, as I previously said, the current standard or the standard up until now has been that we do not treat anybody until they develop end organ damage. The problem with that philosophy is that sometimes the end organ damage can be permanent, and it could have lifelong consequence, and also decrease the type of drugs that we can use for treating myeloma. So, the new definitions, what it has done is now we can, using some biomarkers, we can actually identify patients who are at very high risk of developing the CRAB features. So, we all as a community agreed upon the fact that if you have an 80% or higher risk of getting one of these CRAB features in the next couple of years, then we are not going to wait for the other shoe to drop, so to speak, but intervene right away. So that is the change that happened from the old diagnostic criteria to the new diagnostic criteria. So in addition to the CRAP features, now if you have a free light chain ratio that's more than 100, or if you have a bone marrow plasma cell percentage of 60% or more, or if you have an MRI that shows more than one lesion, then those things are considered as evidence of imminent development of myeloma, and we start treating those patients. So obviously what is happening is some of those patients at very high risk, we are moving them to the myeloma diagnostic group, so we're treating them right now. And some patients with very low risk, they are behaving more like muggers, so we continue to watch them. And the people in between, we need to find out whether intervening early is going to make a difference. And then the question comes, what kind of intervention? Do we treat them just like myeloma, or can we treat them with something less than what we use for myeloma? And or do we just keep treating them intermittently? So there are a variety of different approaches we can utilize in these patients, but we need to do phase 3 clinical trials. Until that time, I think patients who develop, who has a monoclonal protein detected in the clinic, your first step is to see if they have muggers, they have smoldering, or they have active myeloma. If they have muggers, we watch them once every year. If they have smoldering, we watch them once every 3 months, and if you have myeloma, we treat them.